Hello, everybody. Welcome. I see we have a few people coming into the webinar. Welcome. We'll be getting started very, very shortly. So for those of you who don't know me, my name is Ilsa Bird. I'm the Sector Support Coordinator at Your Side Australia alongside Rosanna. So Rosanna is here in the background today. She'll be helping me out. But I'll be hosting our panel today. We've got some wonderful expert speakers for you today who I'm going to introduce very shortly. So our topic today is what can home and community care providers learn from the impacts of COVID in residential care? So today we're going to be drawing out some of the learnings around COVID in the outbreaks that have been happening in residential care in both Victoria and earlier this year in New South Wales. Hopefully we'll be able to provide you with some practical advice that you can take back to your organisation so that you can do some planning if we see an increase in COVID numbers in New South Wales and also in our region. So our panel will be answering a series of questions and we'll be asking for your feedback through a series of polls throughout the webinar. So make sure you're paying attention and keeping on top of things. We'll also have some time at the end, so feel free to use the Q&A function in your Zoom control panel and ask questions throughout the webinar. We will have some time for questions at the end. So before we get started, I'd like to introduce our two wonderful panelists. So firstly, Therese Adami is the General Manager for Community Care at Catholic Healthcare. Therese is responsible for strategic and business outcomes, leading teams to achieve strong sales growth, excellent service and high levels of engagement across the country. So welcome, Therese. Thank you for joining us today. Secondly, we have Michael Hall. Michael Hall is the CEO of Regal Home Health. Michael Hall has many years of experience, senior experience across a diverse range of industries and has operated in the business-to-business and business-to-consumer environments. So welcome, Michael. Thank you for joining us.
Good morning, Elsa.
Morning. All right, well, let's dive in and get started straight away. So our first topic is around lessons that we can learn from residential care. So Michael, I'm going to direct this question first at you. In your view, what were some of the key causes of outbreaks in residential care?
Ilsa, yesterday the Victorian Department of Health put out a report, and in that report they said that the key areas of concern were poor infection control processes, inadequate, inappropriate, poor use of PPE, the lack of social distancing between team members at meal and tea breaks, which is something I hadn't considered, and also the practice of putting infected patients in the same room. From a personal perspective, my daughter Sophie is a theatre nurse and she's working in a public hospital in their COVID designated theatre. And if I look at the protocols she goes through in relation to the use of PPE, disrobing, showering between operations, it's very clear that that would be difficult to do in an aged care environment, particularly with a relatively untrained carer workforce. Yeah. And I look at that and I can see it becomes clear to me why there are issues in that space.
Yeah, that's right. And we're going to discuss some of those topics in a little more detail as well. Therese, did you have anything to add to Michael's answer?
Yeah, thanks, Ilsa, and good morning, everyone. Outbreaks got into residential care through coming into the home. So it's come obviously into Australia from overseas. And it's then spread throughout the community. It has got into residential homes not because the residents have been outside, it's because of typically the staff coming into the home. There's a lot of discussion at the moment, I think, with Scott Morrison and his acknowledgement in lack of preparedness for residential aged care and whether that's responsibility of government, and we could have perhaps done more from a quality and control perspective. But yes, look, it's very, very unfortunate that it has got into a number of homes across the country.
Yeah, I agree. So to begin with, we're going to start talking about the management side of things. So before we head into our first question, we're going to start with an audience poll. So our first polling question is, does your organisation have an outbreak management plan? So when we launch the poll, if you can just click yes, no, or unsure, and then we will share the results with you. Thank you. I can see people are voting. Wonderful that most people are saying yes. That's great. Keep voting. Click yes, no, or unsure about if your organisation has an outbreak management plan. Wonderful. Okay, so I'm going to end the polling there. So we have about 90% of organisations have an outbreak management plan. We've got 0% that have said no, which is wonderful. A few have said they're unsure. So let's get stuck into the first management question. So Therese, this question is for you. So an outbreak is defined as one case. So relative to management and operations, what should an organisation's first response be if a case is linked to their organisation, staff or clients?
Okay, thanks Ilsa. We've had actually 2 clients that have had COVID-19, and absolutely the first response, we've had many more that have been suspected or they've been in contact with someone that potentially may have been infected. And the number one response when we get something like this is we take it very seriously and are very responsive to the person and their situation. So I think that's the first thing, is to be open and listening. The second point is to really get the facts, get the details around caring for that person, whether it is a client or a staff member. What's the health response for that person, and how can we help them with the requirements as a provider that we need to follow? And what are the other risks associated with the contact and what they've been doing in the last 14 days. So there's very detailed questioning from both a client perspective, who may be suspected or have symptoms or been in contact, and a whole tool that covers 27 questions. So we've developed a bit of a tool to understand all sorts of areas from a client: the date we were notified, the date they were tested, have they been tested, what symptoms have they got, their current health status, their likely source of where they've got it from, what region they've been in, program. I could go on a number of areas. Obviously in home care, it's absolutely important to understand when they last had their service, who was servicing them in the last fortnight, and making contacts, particularly with the public health units in each of the local regions. We need to monitor our clients and nurture them. So from a client perspective, we need to understand the facts and more details, as I explained, and we also need to care for our clients. So obviously they're requiring our service as a home and community provider. So what else can we do for them to maintain them to live at home? So is that providing PPE, limiting the staff, looking at the services? Can we provide the services a little bit differently during this vulnerable period? And what's the appropriate PPE that needs to be put in place? We also then need to look at the ongoing care for the staff that have gone in or perhaps going in into the future for this client, and just making sure they're feeling supported and trained with the relevant information. And we also need to make sure that that the client is well, and they do get a clearance and are getting the required medical care from their GP and the public health unit and the care. So really caring for that person and keeping a tool in place where we're monitoring our client and their service, their health, their well-being during this period. From a staffing perspective, obviously similar requirements around keeping a register that has lots of information. We've got 17 data points that we collect around our staff if they're suspected or diagnosed or been in contact with a client around that. So all sorts of things around the date they needed to isolate, what the instructions around isolation, their symptoms, how they're going with their symptoms, their payment status, whether we need to continue paying them because they were in contact with one of our clients and we're asking them to isolate because of their work with a home and community care provider. Obviously the testing, the follow-up, the symptoms and the general health and well-being. We need to make sure we're checking in. I think that's one of the key things as a service provider, caring for our clients and our staff and regularly checking in, working with them. It's a fearful time and making sure we're covering the requirements around working with the public health unit and proper testing. So there's a number of protocols and data points that we need to continue to stay in contact with our staff and clients during this period till they get a clearance.
Wonderful. Thank you, Therese. Michael, I'm going to direct this question at you. So it's recommended that an organisation have an outbreak management plan. What are some key components that must be included in this plan, in your opinion?
Okay, I think one of the first things is a simple one: appoint a pandemic coordinator, somebody that actually is coordinating the efforts, bringing all the different elements, as Therese mentioned before. There's lots of different elements to providing support to someone in the community. And if you look at
Michael, we've just lost your sound. Yes, we have.
Right. Hold on.
Okay.
Have you got me back?
You're back. Let's keep going.
Keep going. You've just missed the most important part, Elsa. The situation is that pandemic coordinator, when you're providing care in the home, it's about the total community. It's about the total support community of that person. So you've got to be in touch with, whether it be the next of kin, the doctors, the other people that are providing services. So it really is a holistic approach to the care of that person. Communication, if you look at a lot of the major issues that happened when the first outbreaks happened in the aged care facilities, a lot of the angst was about the lack of communication with family members. Yeah. And that really has to be, you've got to make sure your communication is correct and you're on top of that. You've got to have your key contacts in place. You know, we've already been in touch a number of times with personnel in the Department of Health when we've had issues that we've had to resolve or discussions, or particularly with clients that were looking for confirmation of policies. So have contacts in place in the Department of Health, in other government bodies or other community organisations that can assist. I think operationally, you have to understand how you can amend your rosters so that you can minimise the risk of cross-contamination. That's something that has to be put in place immediately as soon as you find someone that does have COVID or suspected of COVID. And most importantly, I think, is that you have to have a plan in place for post-outbreak support for your team members.
Good point. Very good point. Thank you. Therese, I'm going to direct this question back at you. So an outbreak management plan doesn't operate in isolation from the rest of the organisation. So what are some of the other operational procedures that might need to be adapted or updated when creating an outbreak management plan?
Yeah, thanks, Ilsa. And I think all of us know that this COVID-19 has affected us in many, many ways, the way we work and live our lives. Obviously, operationally, we've all been spending significant amount of time around preparing and keeping up to date and managing around COVID-19. Operationally, there's a whole number of areas that have been impacted and continue to be impacted. As Michael says, communications and meetings, regular meetings. We have a weekly meeting, community readiness, with our regional managers across the country, meetings as a company level. Outbreak committee, Catholic Healthcare has RACs, so we have to, they're probably more advanced in a lot of ways in preparedness than home and community care, and have to be. And then our training for our staff. So if I'm going through, I'm sure many of us are aware of the training that's been put out through the Department of Health websites, the mandatory training on hand washing and COVID modules that our staff are all needing to undertake, training around PPE, when to use PPE, how to put on a mask and the guidelines around masks, a screening tool. All of the clients that we visit, our staff, before they enter the home, greet the client and go through a screening tool for every service that they need to. So it's changed the community care worker and our care advisors communication, and gives that checking before they enter the home. There's also incident reporting, how we reporting suspected in our incident reporting tool, having drop-down fields around adding COVID and suspected COVID. As Michael says, workforce contingency. If one person is off or needing to isolate, they're out of work, out of the roster for 14 days. So making sure we've got contingency and backup staff, both internally and through broker support. I think that's been one of the big impacts that's impacted RAC, just the whole impact to the workforce and the needing to be isolated or if unwell. Certainly, as Michael mentioned, supply management, making sure our suppliers are compliant with the requirements that the department has put out. So communication with them and signing deeds of agreement to ensure that they're following the same rules that we are, that staff are not to come to work if they're sick. Are they doing regular hand washing, the use of masks, the use of PPE, the training of staff and the screening of clients before they enter and giving us that feedback. So the whole supplier management. As I mentioned, the screening tool when entering a home, but also wellness centres where clients, older clients are coming for social outings or activity. There's the whole consideration around now the space that our clients can be in needs to be larger, doing temperature checks, registrations of people coming in, contacting the clients before hand the day before to make sure that they're well, and so they're not infecting people. So there's been a whole change operationally to the way we operate our wellness centres because of COVID. In terms of procurement, as we know, the masks and PPE and the hand washing, we're now having to monitor the use of equipment and making sure we've got stocks as situations change. So making sure there's adequate supplier management for procuring PPE, and the ordering processes have got a bit more sophisticated. As Michael says, communication. Communication is critical, both individually in the case of suspected or diagnosed or being in contact with someone with COVID, but just general communications. The wonderful document the department put out, which we use quite a lot, It's Okay to Have Home Care, which is translated into different languages. So if clients are concerned or staff, we've been using that tool very successfully. And regular communications through the website, client communication, we've increased our client communications, looked at the types of services that can be provided, use of online a lot more, and really encouraging that through online exercise programs, online seated programs, and moving that through. So there's been a lot more communication to staff and clients, and one of the things that we've put in place through Zoom, you can easily now, and many of you I'm sure are doing recording of scripts. We do fortnightly videos, just a couple of minutes. Our regional managers are giving messages, ongoing reassurance around the screening tool, hand washing, But we're also incorporating other messages. So we've found that we've had to communicate a lot more around training, all sorts of things to let our staff, to keep them informed, but to reassure them. So regular video messaging out to our community staff and also to clients, reassuring them and their family members and giving them messages and reassuring further messaging to endorse what the government's saying around the COVID app. So we did communication to clients around downloading the COVID app, keeping them informed about hand washing and going to the doctors and checking. So there's been a lot of changes around communication. Just a couple more. Impacts operationally. Boards and stakeholders are very much interested in protocols and keeping them informed. And we're still having to keep them informed. And board is asking for greater scrutiny, preparation in the case of an outbreak or suspected and how we're managing. And they're also being very supportive and understanding it's a key focus for us as managers to ensure that we're managing COVID. It's put a lot of extra work on everyone in preparing and managing. Our volunteers have also been impacted as a result of the community transmission. So volunteers are also having to go through screening. If they're not well, they're not to do the volunteer. If they're older or at risk, they're not comfortable going out there face to face. So certainly there's been a big impact to the volunteers face to face, but then how do we use other ways to engage through telephone and electronic communication from volunteers? And then government relations and funding. There's been some subsidy increases for home care packages, so communicating that subsidy change to our clients, but also covering the costs associated with COVID, and then obviously for the CHIS, the flexibility arrangements that have been put in place to look at how we can provide services to clients out in the community, but within the limitations of the funding, perhaps that have been a bit restricted with wellness centres closing, and the flexibility that's been put in place to put one-on-one social support. So there's been a whole lot of operational impacts that we've had to look at around how we deliver CHISP, how we spend the hours, and how we can work with our RAS teams to really make a difference to older people at home that are still vulnerable, but perhaps need care in a different way during this time. That's a few areas operationally.
Yeah. Look, like you said, I mean, an outbreak management plan isn't just a document that you have in your organisation because you need to. It's something that's going to impact every area of your organisation. COVID is going to impact every area. So thank you for that. I think it's really important to remember all those different things that need to be included. And just a reminder to everybody as well, I see we're getting some questions coming through on the Q&A, which is wonderful. We will be answering those at the end of the session. So please keep them coming through.
Yeah, it's just what I was going to mention in terms of that outbreak management plan.
Yep.
I think you mentioned it's not in isolation. To me, the outbreak management plan is an extension of your pandemic plan. And the pandemic plan itself has to sit within your clinical governance framework. And if you don't have a clinical governance framework, then I think it's very difficult to be able to implement that plan. So I think it really is just an extension of the way that you operate your business, the framework in which you provide that clinical governance, and both your pandemic plan and your outbreak plan both come out of that framework.
Yes, that's exactly right. Absolutely. Okay, so we're going to move on to talking about staffing now. So that's something that Therese, you've mentioned, and I think Michael, you've mentioned that as well. So we're going to look at our next audience poll. So poll 2 is, does your organisation have a workforce contingency plan? So if you'd like to answer that, please attendees, does your organisation have a workforce contingency plan? Yes, no, or unsure? And once we've got a few answers coming through, we'll have Michael and Therese answer some questions about staffing and workforce planning as well. Still getting some votes through. Couple more to come. Okay, awesome. Thank you, everybody. So as you can see, we have 72% have said yes, 12% have said no, and 16% have said unsure. Thank you, everybody. So let's launch straight into our next set of questions. Michael, the first one is for you. So in aged care, we have a highly casualised workforce, which can be challenging when organisations are short-staffed. So what are your recommendations for workforce planning and emergency staffing during COVID?
I think the first thing is to know your workforce as best as possible, or as much as possible. One of the things that we've done is we've done quite a number of surveys on our team members to find out the gaps in information that we didn't have previously. I'll give you an example. We've covered areas such as if there are school closures, will your availability be affected? That was an issue when we went back sort of that April-May period. We also asked the questions about what other organisations do you work for in the health industry? If one of our casual team members works for Newmarch House, for example, we need to know about that.
Absolutely.
So we actually required more detail about the people that work for us than we had previously. So that was one. I think, and Therese touched on this before, in COVID, so in the era of COVID, you need a larger workforce. You simply need more people. Yeah. So we've actually have had to increase the assistance to those that are recruiting. So that's one of the things that we've had to do. We've also built up what we've called a Regal Reserve, and Regal Reserve are people that we can call upon. So we reached out to past employees, past nurses, past support workers, to see if there was anyone that did have availability, even if it would be for a short period of time, for a day or a weekend or whatever, so that we actually have a group of people that have worked with our organisation before that we can actually bring back in now to assist if we need anyone else at short notice. So there are a couple of things that we've done.
Yeah, wonderful, wonderful. Therese, this one's for you. So often care workers work with more than one organisation and across home and community care and residential care, so as Michael mentioned. So what should organisations put in staff to reduce the risk of transmission if a staff member is linked to an outbreak with another organisation?
Yes, look, thanks, Ilsa. I mean, I think the key for any employer is to be a good employer so that staff want to work primarily and get the sufficient hours, job satisfaction, training and pay. So we're all obviously seeking to operate as a good employer where we can meet the needs of our staff and provide them with the requirements for a good employer. Obviously, some people do choose to work for other organisations, and we actually, similar to Michael, I'm sure many of you surveyed our staff to find out if they work for another employer, and we found out that they don't just work for other home care providers or residential aged care providers. They're working in other types of work. So understanding that the amount of staff and where they work is quite interesting. In the case that there are locations that perhaps have been exposed to COVID. So in New South Wales, it's not mandated that you only need to work in one aged care provider. In South Australia is definitely looking at that. And obviously we can't control people's work lives. We don't have full control of where they work, and they are free to do whatever they want. And I think that's an important principle that we need to operate on. We also would promote the principle of good self-management. No one wants to get COVID and no one wants to be exposed to COVID. So all of the communication and all of the training that we're doing around hand washing and social distancing and is a principle that we're all trying as Australians or across the world to prevent contracting, or if perhaps we've contracted it, spreading it. So I think reinforcing all of those messaging around hand washing, coughing, don't come to work if you're unwell has been a very, very important principle that I think was linked originally to the new March and situation there. So definitely not coming to work if you're sick, and then looking at paying staff and what's the payment if we're asking them to isolate. So I think putting in place to be a good employer, that is an important principle that we need to be prepared for. As Michael says, what's the contingency, what's our broker management agreements, and what is the arrangements to make sure that they're compliant. For locations, doing the prevention factors that I talked about around temperature checks and distancing, and also making sure that you come to work with a clearance. So if people have been unwell, that they are not coming back to work without a clearance, that they are COVID negative, is a way to reduce transmission for the organisation. And then obviously in the office, physical locations, all of these distancing and hand washing and coughing and all of these not coming to work is absolutely critical in reducing the transmission.
Yeah, absolutely. Thank you. Okay, we're going to move on to talking about infection control now. So we're going to launch another poll. Okay, here is our third poll. So firstly, have you undergone infection control training during COVID? Yes or no? And the next one is, have you received training for the correct use of PPE? So this is very important information for us to know. It also helps us in sector support to know if we need to do any further training on infection control, or if you need some more information around the correct use of PPE. I'm getting some votes coming through now. Thank you, everyone. And I can see we've still got some questions coming through, so please keep them coming. Another couple of seconds. But most people have voted. Right, wonderful. Thank you, everybody. So as you can see here, we have 88% of our attendees have undergone infection control training during COVID. 12% have said no. In regards to receiving training for the correct use of PPE, we've got 88% have received training, 12% have not received training. Thank you, everyone. Okay, so let's get stuck into the questions. Michael, this one's for you. So infection control, we know, is one of the most important keys to stopping the transmission of COVID. So what are some of the common gaps in infection control that can put staff and clients at risk?
Okay, well, I think the first one we've talked about a lot, and we're probably going to talk about a lot more, is just the correct use of PPE and also the availability of PPE. If we went back to that March-April period, getting PPE was very, very difficult. And we found ourselves having to find people that could make cloth masks for us because we couldn't find surgical masks.
Yeah.
And we realised very early on that if we didn't have PPE, we couldn't provide the services to those we're looking after. So we've spent a lot of time resourcing. We have good inventory levels. We keep a minimum of 3 months in advance of PPE at all time to cover that side. I think the other thing is that you've got to have policies where there's no room for personal interpretation. I'll give you an example of that. We had a client that stated his mother was coughing, showing cold or flu-like symptoms, and the next of kin, the daughter, said, well, mum hasn't been out, there's no need to have the test done. You can't have grey areas when you're talking about COVID. You have to have policies, they have to be set, there can't be personal interpretation on those, and you have to be consistent. I think the other thing is that you've just got to have really clear lines of escalation. So when you do come across somebody that has COVID-like symptoms or someone has tested positive for COVID, The team members out in the field have to know what are the processes, who they have to escalate the issue to, and then you have to have the personnel available to handle that from a clinical or operational basis. So it's just that consistency and clear communication, once again, right the way through your organisation.
Yeah, great point. I think you're absolutely right. Grey areas, that's where all the problems begin. If there's clear policies and procedures, everybody knows what they're doing, then we won't see those gaps in infection control. Thank you.
Or you minimise the risk of that happening anyway.
That's right. That's very true. Okay, Therese, this one is for you. So earlier this year, the government found cross-infection in residential facilities was due to incorrect use of PPE by staff who weren't correctly trained. So what are some of the most common misconceptions around PPE and infection control training?
Thanks, Ilsa. It's an interesting one. I asked someone this question and they said to me, when I asked them what was the biggest misconception, and they said, well, that I'm not going to get it. And I think it's actually very true, because we all don't think we're going to get it. So I think that's one misconception. I'm clean, I'm doing the right thing, I'm doing the hand washing, I'm never going to get it. So that's one misconception. I think another misconception is that I've done the training, I know how to do hand washing, I don't need to do it again. So reinforcing that practice. I think the issue around masks has changed over the last 6 months. Certainly at the beginning, there was the requests, we were getting a lot of requests about masks. There was really no clear policy from the government or the practices around masks. That's now changed. So I think there's a lot of misconceptions around masks and things that were information for me around cloth masks. So cloth masks really aren't deemed as yes, they're a protection, but they're not deemed as a good infection control practice. The conception around touching your mask, and you can use, and different people have different policies around masks. Do I need a different mask for when I'm in contact with the new person? And no, you don't. So you can use a mask for up to 4 hours. So I think there's that the misconceptions and clarity around masks is something that needs demystifying. How do you put on a mask appropriately? There's instructions, and how do I get rid of masks and how I dispose of them correctly as well. So yeah, they're probably the main misconceptions around.
Great point. I love your point around training, Therese, that because you did the training back in March doesn't mean, okay, I'm trained, I'm qualified, I know what I'm doing. So good to always continually refresh your memory around those practices. And we are learning more things every single day, particularly around mask disposal, making sure we're not touching masks, how long you can wear a mask for, the order of donning and doffing PPE, or all of those things. It's really new information for a lot of us. So it's really important to continually train.
Yeah, and the experts in government don't know all the answers. They don't know everything about this virus. They don't know how to treat it. So we're still learning new things. So the importance of keeping up to date on what's happening.
Absolutely. Very, very true. Michael, this one's for you. So it's all well and good having a quality infection prevention and control program on paper, but how can organisations embed these practices into organisational culture?
I think that's a very difficult process. It's not easy to change culture or embed anything into a culture. I was looking at this question, and I thought I'm actually very fortunate in that Regal is a clinically based organisation that's moved into the supply of personal care and support services. So clinical procedures and clinical governance are part of our DNA. So if you're actually coming from the other perspective, where you've provided personal care or support services and you're now trying to build a clinical governance perspective, it's difficult. But like anything, the way to do it, I think, is just having very consistent and clear communication. You know, you've got to be able to say, you've got to be, the message you've got to tell anyone, I think, a minimum of 4 times before anyone actually starts to understand the changes and what you're trying to bring into play. So from our perspective, we try to make sure that our message from orientation and at every stage of our team members' journey is consistent and clear. I think that's really what we have to do. So you have to be consistent, you have to mention it, it has to be mentioned once, twice, 3, 4, 5 times. And particularly when you're starting to talk about the aged care standards and the requirement for our team members to be aware of the aged care standards, that's a really difficult thing to get across. How do you do that? You know, we've looked at having little badges made for lanyards. Right? So people actually have the standards with them. We've got the app on people's phones. So wherever they look, they can see the standards and start to understand what those standards for aged care are. So once again, you've almost got to flood the messages. You've got to get your messages out there and you've got to find new ways of doing that. I think with a remote workforce, so our workforce is remote, we're working in the home, the use of technology has become really important. We have a web-based system which makes it quite easy to make sure we have all the information about our clients at hand, but also the use of other technology, Microsoft Teams. You know, I was saying before to Therese, there are some areas that I've learned a lot from. And the use of Microsoft Teams and the way we communicate, the way we can train, the way we can share screens, the way that we can communicate with our team in the field has changed. And I think it's one of the, if there's anything good that's come out of COVID-19, it's the way that we're using technology to communicate, train, and interact with our people in the field. I think that's improved in our organisation.
Yeah, excellent. I love that you brought up the topic of communication, because that's what we're going to move on to talking about next. So I'm just going to launch the next poll. So this one is all about communication and how organisations communicate. So the first one is, what is the most common method utilised to communicate with clients in your organisation? And then what is the most common method utilised to communicate with staff in your organisation? So if I could ask you to vote there on what method of communication is used in your organisation for staff and clients. And if you do choose other for either of those questions, we'd love to hear what that other method is. So please, can you pop it in the chat panel if you have something that we haven't thought of on that list there, please. Got lots of people coming through voting. So the options for clients are email, social media, mail, phone, text message, and other. Staff communication is via email, staff portal, face-to-face, an online meeting platform. So for example, Zoom or Teams, and other as well. We've got one in the chat, video messages to customers and staff. Thank you, Sue. Okay, just another couple of seconds. If you haven't voted, just pop on there now and pop your vote in. Okay, great. Thank you, everybody. Okay, so in terms of communication with clients, we've got 31% through email, 19% with social media, 4% in mail. Phone is the most popular message, most popular method at 38%, and other as well. And we've got a couple of responses on there: e-blast and SMS to clients, letter drop off, communication with by correspondence. And then staff communication, we have email was the most popular, 62%, 19% through a staff portal, 12% face-to-face, 4% with an online meeting platform, and 4% for others. So thank you, everybody. So we're going to now jump into some questions about communication. So Therese, we're going to start with you. So communication is essential to reassure staff and clients during COVID, and I know we've already brought up this already, and even more importantly, if a case is linked to an organisation. So what is the most important information that needs to be communicated to A, staff, and B, clients?
So yeah, look, I think it depends on the situation. Obviously, two-way communication is absolutely critical with either staff or clients. And thanks for the poll. I think a lot of those areas we're using multiple assumptions. So I think we're not just doing text messages or emails or videos, we're doing them, we communicate in different mediums. And as Michael says, I think COVID's really helped us around our video communication and more team Zoom, direct one-to-one video and more team communication. The government has also put out the apps, so the website, we've encouraged our staff, they're all provided with mobile phones to download, they've got to check the New South Wales app throughout the day to look for the hotspots. It was just getting very challenging to look every day and have to get out to people who live in southwest Sydney, if you've been to the Crossroads Hotel or if you've been to this Thai restaurant, and as we know, the suburbs and locations of hotspots are changing every day. So really encouraging particularly staff to take responsibility in their own life, which they need to do anyway if they've been to any of these locations. So I think that's been absolutely important to download that app and to empower people to find out the information themselves. Also, the communication tools around that the government's putting out, there's a lot of resources on the Department of Health website and the New South Wales website. So really trying to refer people to those tools that are available. As I said, that it's okay to have home care. Brochure has been highly valuable in terms of important information. Our role as providers in society, we want to reinforce the messaging that the government's putting out around all of these good practices around the COVID app and hand washing and distancing that we all need to constantly hear and comply with. Communication obviously is, as we know, it's two-way, but also training is important. So it's not just we're asking, communicating something, but also proper training. And then reinforcement and checking. So really reinforcing good practices or checking on practices that perhaps aren't being followed. So for example, we're asking people to wear masks if they're doing personal care. Are we going in checking? Are you actually doing that? So I think sometimes as leaders, it's easy to blast messages and hope they get through. And we try and do it in multiple channels so people can hear it and read it. But in this age of multi-communications, really just being very planned and structured and going back and then checking and reinforcing and promoting the good stories. So yeah, I think communication around COVID, both prevention and if you have been diagnosed or if you've been exposed, then that individual one-on-one as well as group communication is important to have as part of the communication mix.
Great, yeah. And you mentioned two-way communication, and that's what I'm going to direct this question to Michael now. So as Therese said, communication should always be two-way. What information is important for clients and staff to disclose to their organisation?
I think the first thing you need to do is to actually look at your referral process. If you look at the referral process, what information are you getting? Do you need to change your referral process? What other information do you need during COVID to be able to find out where are the dangers, where are the risks? So I think that's the first thing. I think the other thing to do is also for the organisation to review the contact information they have on those they're looking after, making sure that we do have the next of kin. We know who the people's GPs are. We know who's going to be in their support of their community. I think that's fairly important. And if you don't have that information, then you need to be able to get that information from your clients. So in terms of two-way, we have to be looking at the information we have. We then have to then go out back into the with our clients and find out what information we need to fill, so we've got a complete picture of that person and their own community. Obviously, if our clients are feeling unwell, they need to advise us of the symptoms. They need to let us know if they've been in contact with anyone that's been COVID tested, or if anyone that they know has been proved to be positive with COVID. So that's information we need to have straight away. I think from our, with our casual workforce, we've mentioned it previously, that we have to know where they're working, if they've been, as Therese said, have they been into hotspots? And once again, we have to have that communication available, or lines of communication available, so they can actually tell us this information. I think the other really important thing that, and Therese mentioned this just as well, is as an organisation, you've got to have immediate feedback if your team members aren't following those protocols. You know, if somebody is going into a home and they're not wearing a mask, or if they're not following the procedures you've got in place, you need to jump on that straight away. And so that's sort of that two-way communication. You know, we can actually go out there, we can tell our team members what they've got to do. We've also got to be able to monitor, train and assist to make sure it's actually happening.
Yeah, great point. Okay. So we've been very efficient today. We've flown through our questions. So now we've got plenty of time for some Q&A from the audience. Now we did a pre-attendance questionnaire. So thank you for all of the registrants who completed that. We have a few questions prepared there, and I can see we've got a few that have come through the Q&A panel as well. So let's jump straight to our questions. Okay, Therese, I'm going to direct this one to you. So this question is from an organisation who has a large volunteer base. So they've said, we stood down volunteers until further notice. Some are very keen to return. When should we be bringing back volunteers, and should it only be those who are under 70?
Yeah, look, good question. So thanks for that. We at Catholic Healthcare also have volunteers, both in home and community, and also residential aged care. So they're two different settings. So I would say we've been very, very conservative around the residential aged care. We know in residential aged care, a large proportion of residents don't have contact and don't have family contacts or family supports, and the volunteer can be a significant person in that resident's life. So there's been a lot of work being done on, you know, as we've seen the media, communication through the windows, through video conferencing, through staff having to assist the resident to communicate with family or the volunteer. So there's been certainly the restrictions in residential aged care, and they're constantly looking at the tier restrictions based on the location and the home and where they're at. So in terms of residential aged care, that has really not been, I don't believe there's been any face-to-face, but there has been volunteer communication in residential aged care through these other mediums. In terms of home and community care, we have commenced face-to-face visits, and that depends on both the volunteer and the client. And similar protocols have been put in place in terms of the screening tool for the volunteer and for the client, to make sure they both haven't been in contact with someone, that they're not symptomatic, that they're feeling well, that they're following the social distancing. So they absolutely need to follow that social distancing rule, and also wear a mask. So there has been a recommencement of the volunteers face-to-face. As I mentioned, there's a lot of continual communication with volunteers and clients through other mediums, through a tablet that is provided, through video conferencing, through encouraging the volunteer help unlock other socialisation and connections, both with the volunteer but other significant others in that person's life. In terms of the age, yes, there is. It is recommended that if you're an older person, that you don't do those face-to-face communications. So it's really dependent on both the match between the volunteer and the client, and is that a safe reconnection to have face-to-face. So it's an individual. The volunteers do need to sign, similar to the staff, that they're not going to come if they're not well, that they've had the flu injection, that they're following all of these practices. There's been, for volunteers, and I saw something, there's been, their insurance doesn't cover them, the volunteer insurance, if they've got COVID through their volunteering work. So there's some work being done from the volunteering industry to look at how we protect both the organisation and the volunteers in the case of contracting COVID. Does that answer that volunteer question?
Yeah, sure. And Michael, do you have anything that you would like to add to that answer? You're on mute at the moment, Michael.
I think Therese covered it pretty. I think the only thing I would add is that if you've got your protocols in place, that's the key. You know, if you're using your protocols for your casual workforce, they should be applied equally to your volunteer workforce, particularly in the home care area. Yeah, that's the only thing I would add to that.
Yeah, absolutely. Okay, next question. So Michael, I'm going to direct this one at you. What strategies have been devised to engage clients and encourage their participation with essential infection control, such as hand hygiene, and understanding what requirements are for their attending support workers?
Okay, so I think first off for us, it's been communication. One of the first things that we did was we set up on our website a COVID-19 button on our front homepage, so that all our communication was up there straight away. Our pandemic plan was there. We then sent out communication to all our clients, both in email and also in written form. You know, we have many patients that are over 90, so we made sure that we provided both soft and hard copy, so they could actually understand or get a picture of what we were trying to put together. The communication that we put out to our clients was also provided to all our team members, so that they actually got a copy and they actually knew the messaging that we were putting in. So once again, we had consistent messaging from Regal management in terms of communication, and also for the people that are looking after those people in the field. We've also, once again, I mentioned before that we've done a number of surveys with our team members. We've also done surveys with our clients in the field, just to feel how they are they comfortable, what is the feedback that we're happening. The other thing which has assisted is that some of the funding bodies have changed some of the programs. So we do a lot of work for the veterans in the home, and DVA has now actually provided telehealth options, so that we can actually provide telehealth. So if one of our veterans is not feeling comfortable with somebody coming in and providing care in the home, we can do a weekly check. We can call. So I think some of those things have changed, and that's how I think that's made a big difference in the way people are feeling, and also helping to reduce social isolation.
Yeah, excellent. Okay, Therese, I'm going to direct this one at you. It's around a brokerage model, or I guess utilising subcontractors, that there's inconsistencies across in-home care providers about the use of PPE. For example, masks for workers and customers when they're less than 1.5 metres apart, so where social distancing isn't possible, and also lack of customer education when providing brokerage. So some providers are very, very proactive and others show disinterest. So how do you cope with this in terms of risk management and inconsistency between organisations if you have that kind of brokerage model?
Thanks, Ilsa. Yeah, good question. So as an approved provider, many of us will have been surveyed and contacted by the agency about our compliance and our readiness and our protocols around COVID. And one of the specific questions they asked us is around our brokerage management and supply management. So it's absolutely an expectation as an approved provider that we take responsibility for the quality of our suppliers servicing us. So in the case of whether it's nursing or community work or other allied health, we've got a responsibility as the approved provider to make sure that they comply. So it's been important. Our goal has been to have in-home staff. We believe that that's our preferred option, to have staff employed by Catholic Healthcare in terms of quality training to help minimise that. But as you know, we all need contingency, and some of us have models that we don't choose to have our own staff. So it's been a management, I guess, task in supply management, which is what we already have in place in compliance with all the insurances. There's been a number of communications that we've gone out to our suppliers and asked them to confirm their compliance with certain requirements that are in line with being an approved provider. So they've had to sign a deed to say that they are complying with the same protocols and practices that we have in place. So staff are not coming to work if they're sick, that if they've been in the hotspots, that they're to isolate, that they've got the PPE practices, and their staff have had the training. So the same rules that we have internally, it is harder to control and manage because you're relying on them. So some level of agreement and some signatories to ensure that's happening. And then I guess the next step is then checking that that's actually happening, either through auditing, random audits, or through client feedback that's in place. So yes, it's another area to manage brokers, because you don't have the control. They're all different, but I'm sure we all go through quality, both looking at quality and cost of brokers and ensuring that they're meeting our standards in line with our vision and values and goals and of the organisation. Does that answer that question, Ilsa?
Yeah, absolutely. We had one of our other attendees ask a question about following the deed of agreement, so you've answered that too, so well done, thank you.
Okay.
Michael, did you have anything else that you'd like to add to that question or the answer?
I suppose I actually come from the other position. We actually provide brokered services to lots of non-profit organisations, so clinical services. And for us, it's making sure, once again, it's the referral process, that if somebody is asking us to care for one of their clients, we have to know as much about that client as possible. And so, as I said, we've changed our referral requirements, we've updated them. We try to get as much information about that person as we can, so that we're providing that service safely and well.
Yep.
Excellent, thank you. Okay, so we're going to move on to some of the Q&A that we've had throughout the webinar. Okay, here's one. Michael, I might give this one to you. So online platforms have an independent worker model. What risks are associated with this workforce model during COVID? And I believe this question is talking about using workers on an online platform where you can just choose your worker.
Yeah, I think the risks are significant. Once again, I think I've been consistent through this webinar about talking about clinical governance. And really, what is your clinical governance model if you have an online web service? How do you provide that clinical governance when the relationship is between the client and the worker, and in some ways you're just clipping the ticket on the way through? I'm certainly not against the online web model. There is certainly a place for it, and it's actually the fastest growing part of the in-home care market. So there is certainly a demand for that. But if we're talking about COVID, I think it would be very difficult to put those structures in place to ensure that you're minimising risk. I think you're relying on a little bit more luck than I would like to be able to do. And I think that itself was problematic. One of the concerns that I have is that in home care, we've been very fortunate so far that we haven't seen mass contaminations in home care. It's been very safe. Geraldine Doog did an interview or a series of reports on the potential for infection in home care. And so my concern from an industry viewpoint is that an online model that doesn't have clinical governance can have an impact on the way that the industry is viewed by not being able to control the infection or the risk of infection out in the community.
Yep, absolutely. Therese, did you have anything that you'd like to add to that?
Yeah, look, I'd support Michael's comments. I think we've been talking in this last hour about all the different things that have needed to happen as a result of COVID-19, and they're absolutely real. And they take management expertise, they take people's time, and they're a cost to the organisation. So certainly undertaking the training is required. Keep that two-way communication in my view, needs to happen. And it's very, very important to have to continue quality services to our vulnerable aged clients in their own homes. And our average age of the clients at Catholic Healthcare are 83. So they're absolutely in this vulnerable group. And I think if we look at the residential aged care, they're more vulnerable because they're all in the one place together. So from my perspective, it would be irresponsible not to be doing the things that we're doing around screening tools, what we know around training, making sure we've got all the PPE, all of the different things that we've covered in this webinar. So yeah, I'm not sure that does occur in online models. I can't comment on that, but to be a provider out there, I think these absolutely need to occur.
Yep, absolutely, I agree. Okay, so just to summarise all of our discussion today, we've talked about so many things around communication, around management, around staffing, infection control. I'd love to just hear from both of you as to what your top 5 things that a community care provider can do right now. So when they go away from this webinar, you know, give them a list of 5 things that they can do straight away so that they can be really well prepared for what might happen over the coming weeks or coming months for New South Wales and also for our region. So Michael, I'm going to throw to you first.
That is a question. All right, so the 5 things I looked at was, I think we've talked about it, communication is key. Use whatever channels that you have at your disposal to get your message out. So whether it be your website, newsletters, emails, Microsoft Teams, use all those channels and be consistent with that message. I think at the first sign of your team members or your clients having cold or flu-like symptoms, they need to be tested. And in the case of your team members, they have to be stood down until you've got a positive test, and you have to verify that that test has come back. Before they start work, you have to verify that the test is negative, as Therese mentioned earlier. You've got to really you've got to establish strong COVID-19 protocols. You have to have your pandemic plan, your outbreak plan. You've got to have established communication for lines of escalation. That has to be done. You've got to maintain your COVID-19 risk registers, and you've got to provide that immediate feedback if people or if members of your team are not following those protocols. I think that's really important. As I mentioned before, no room for personal interpretation. You can't have grey areas in COVID-19. You can't have team members determining whether a protocol should or shouldn't be followed based on the circumstances. It has to be set. And of course, the last one is PPE. You've got to have adequate, appropriate PPE, and you've got to have the right training in place.
Excellent. Very good. Good tips. Therese, what about you? What are your top 5 tips?
Top 5. I know it's a tough one. We've covered so many different areas, so I'm not discounting the other areas. Similar to Michael, communications. Obviously, that changes all of the time. And as I said, we're getting emails every day, and you have to read them and look at them and decide whether you act and then how and when you communicate. So keeping up to date with communications from the government as they come through and as practices change, both state and federal governments, both communicating and keeping up to date with both of their communications and deciphering that. The screening tool is a very important tool in my view, in terms of when a client is being visited by a staff member or when they're attending a wellness centre. So really screening the client around their exposure, their symptoms, hand washing, all of those sorts of things. So that's an individual one-on-one risk management mitigation strategy. That's the second. The third one, as Michael says, is the COVID protocols, the outbreak protocols, which are quite extensive around training and practices and policies and procedures, and having the PPE available to support those policies and practices that we've put in place. Fourthly is staff and workforce engagement. So really engaging and communicating with the workforce so they're not scared. We've found sick leave has been higher over the last 6 months than what it has been previously, because people are following that practice, but that also has the other side effect of then being able to deliver services. So having contingency within the workforce, but also our third party as required in the event of an outbreak or extensive contraction of virus. So having the workforce available to deliver, either because staff are off sick or needs increase. And then finally, the last thing, which is what we put in place when we first had a client and staff members, is that I mentioned earlier, all those questions, so we can have a register to really track and understand what's going on with that individual client or that individual staff member, who they saw. We developed some really nice reports that we can automatically identify who the client saw in the last 14 days or who the staff member saw in the last 14 days, so we didn't have to go manually each time. So really having a nice spreadsheet where you can manage each individual staff member and each individual client, and it ticks all of the things that need to happen around contacting the PHU, have they got any symptoms, so it keeps us on track on an individual basis. So they've been two very powerful tools to make sure that we close off the requirements for both the clients and the staff. That's my final one.
Great, thank you. Well, that brings us to the end of our webinar today. I think we've really discussed some very important topics, and thank you so much to Therese and Michael for joining us today. Your expertise has been wonderful, and I hope that our home and community care providers can go away today and have a think about some of the ways that they do things, particularly in terms of planning and preparation, making sure that you're acting now, acting quickly. The whole organisational approach, particularly as Michael said in relation to clinical governance, very, very important. And also making sure that you're having those clear protocols and procedures so that there's no grey areas and everybody knows what they're doing. So to all of our attendees, thank you for joining us today. We hope that you've learned something. We hope this has been helpful. As always, you can contact us via our email, myself and Rosanna, sectorsupport@yourside.org.au. And after this webinar, you will be redirected to a feedback evaluation survey. So please let us know what you thought, if you'd like to do this again, and give us all your feedback. So yeah, thank you very much, everybody. And we hope to see you in our next webinar.
Thank you, Ilsa. Thanks, Michael. Bye, everyone. Bye, everyone.
Thank you, Michael. Thank you, Therese.